Good morning, all.
Good
Good
morning,
morning.
sir.
Welcome to our today's lecture. We are still on the course AUM 221, Action and the Uses of Medicines. And the topic for today is musculoskeletal system and joint disease drugs. Musculoskeletal system and joint disease drugs. Based on your curriculum as second year pharmacy technician students. Okay, so from the term in your anatomy and physiology, musculoskeletal system is part of the topics there. So that should be in your ANA 241. Right? Are you with me? Please speak up. Let me be sure that you're following. You've done
Yes, sir.
skeletal
We are
system.
with you.
You've
Sir,
done
we are-
you've done you've done skeletal system in your anatomy and physiology now, right? Ana 241. Please let's make this class engaging. If I ask question, unmute your mic and answer. Please. If I ask question, unmute your mic and answer.
we have not been taught, sir. We have not been taught, sir.
You've not done
Yes,
skeletal
sir.
system in your anatomy and
Yes, sir.
physiology.
Yes, sir. Yes, sir.
Okay,
Yes, sir. We know, sir.
it's okay.
We have not been taught. We have not been taught, sir.
It's all right. Now, so from the term musculoskeletal system, we are talking about musculoskeletal system and joint. There are three things we are talking about here. The skeletal system, the muscular system, that is the muscles, and the what? The joint system. So the skeletal system is made up of bones. Please, mute your mic. This is disobey my ear, please. You know I'm using mic. I'm using an earpiece. The skeletal system is basically made up of 206 bones. 206 bones. Alongside cartilages, ligaments, and tendons. Why I say tendon is because even though, yes, tendon is more in the muscle, but tendon attaches the muscle to the bone. So that's why I say mention tendons. Now, the major function of the skeletal system is to support and stabilize the body. Another function is to protect the internal organs. Another function is to facilitate movements. And that function is that it produces, is very important, it's vital, very important in the production of blood cells, erythropoiesis in the bone marrow. It also serves as store for minerals like calcium, name them, in the bones. So this is not an anatomy class. I wouldn't want to go deep. This is just what I want you to know about what the skeletal system before we go. You know, this is AUM, it's not deep pharmacology. So I wouldn't want to start going deep. I just want to let you know what you should know based on your what curriculum. Then in your anatomy, you can, that's where they will go a bit deep into all this, even the pathology, pathophysiology. Now, remember I told you that the skeletal system, under the musculoskeletal system, I mentioned the skeletal system, muscular system, articular system. So I've talked about the skeletal system. Now let me talk about the muscular system. Muscular system is made up of, from the term muscular, it is made up of what? Muscles. Now there are three types of muscles: skeletal muscle, smooth muscle, and cardiac muscle. Skeletal muscle, smooth muscle, and cardiac muscle. Skeletal muscle is responsible for the voluntary movement, such as you can see, flexion. Have you done an anatomical terms like flexion, extension? Have you done that in your anatomy and physiology?
Yes, sir.
So if you do this, is flexion, right? This one is what? Extension, right? So the skeletal muscle is involved in the voluntary movement. So it is voluntary because I intentionally decided to do it. So as I do like this now, I'm intentionally doing it. So is that why it's the word voluntary movement? I can decide to go out of this office. Yeah, I decided I cannot just stay and my muscle will just get activated and I find myself outside. No, I voluntarily want to do what? Move. So that type of movement is the most responsible for that is what? The skeletal muscles. Now, for the smooth muscles are found mainly in the internal organs, like your stomach, your intestine, your liver. Sorry, I mean, what is it called? Other internal organs, apart from the heart, is found in the internal organ. This one now controls involuntary movement. Note that point. Involuntary movement. Because as you come out, once you eat food, even without eating food, the muscles of your esophagus down to your stomach, down to your intestine, carry out movement we call what? Peristalsis, right? You not decide for that movement to occur. You may just be like this, the movement will take place. So all these things are controlled by the autonomic nervous system. I wouldn't want to go into that. Specifically, the GI, specifically the enteric nervous system. What I want you to know is that the movement there is what? By this muscle is what? Involuntary. I've mentioned the gastrointestinal motility. That is the peristaltic movement. Then cardiac muscles. Cardiac muscles are found only in the heart, from the term cardiac, the heart, only in the heart. And they are responsible for the involuntary cardiac contractions. Is this contraction that helps in pumping the blood? If there's no such contraction, sorry, there will be a decrease in the amount of blood and coming out of the system. The cardiac output be very, very low. And it's a problem because the tissues will not be perfused. As in, I mean that the blood will not get to the tissue because it's when the heart pumps blood, that's when the blood will pass through the ascending aorta, come down to the descending aorta and travel from the aorta to other arteries, from arteries to arterioles to capillaries to tissues, and to get to the cells. Apart from decrease in cardiac output, if there's not much contraction, if there's issue with this involuntary contraction of these muscles, there will also be a problem with blood fluid accumulating in the heart. So we have what's called you have what's called cardiac congestion. And it's not just that, all the veins, all the vessels that bring blood, deoxygenated blood and waste deoxygenated blood to the heart will become congested, and there will be edema in some part of the body. So let me not go there. I just want to let you to know the importance of this word contraction. And you don't control that contraction. It's involuntary. Please note the point here. Skeletal muscles contraction, voluntary contraction, smooth muscles, cardiac muscles, involuntary contraction. Let me just pick some people that are just coming now. I don't know why people like coming late to classes. Okay, let's continue. So that's the extent I can go on the muscular system. Let's look at the articular system, that is the joint articular system. Of course, you know that the joint is a meeting point of one bones, and the ligament is there to fix. The ligament is just like the rope tying the two bones that come together. Of course, there should be a kind of space, synovial cavity, so that there will be kind of movements, and the movement that is expected of the skeletal system. Let me not go deep. Now, joints are classified into three. We have the one we call synarthrosis. These ones are immovable. They are under the group synarthrosis, was immovable joint. Things like a skull. It's called a skull. It's immovable, even though yes, you're moving, but your skull is not moving. We have amphiarthrosis. This one is those one that move slightly. They don't move like that, slightly, like your pubic symphysis, just slightly, and in your pubic area where the two girdles meet, the two pelvic girdles meet. Then we have diarthrosis. This one there's free movements. Your shoulder joint, as you can see what I'm doing now. There's free movement. When I was tender, I used to do like this and do this, and I will not separate my hands, and I will turn to tell you how this place, how movable the shoulder joint is. Okay, now let me see someone in. Lawal, if I catch you, I will knock your head. If I catch you, I will knock your head. Lawal, let come. If I catch you, I will knock your head. Distract now, class up and down. All right, let's continue. Who is this human being again? Okay, so let's continue. Let's just look at, let's just say one or two things, because we've talked about normal physiology and so anatomy and physiology. So let's just talk about a bit of the pathology disorders before we can now go into the drugs. Because if you don't have an overview, an idea of what this system and their disorder is all about, you'll not be able to understand the drugs and what they do. So let us say one or two things about the musculoskeletal disorders. Musculoskeletal disorders. So musculoskeletal disorders, they are common across all ages. Of course, now, even though yes, they are one that appear to be associated with the elderly anyway, but they are common across all ages, and they cause a lot of pain and disability. Pain and disability, very important. There are a lot of nerve terminals that innervating different parts of the musculoskeletal disorder. So any issue there will be what? Pain, serious pains. Now, the first one I want to also look at is injury and trauma. Injury and what? Trauma. So the possible injuries you may see that may associate with musculoskeletal system is things like blunt, blunt blunt trauma, sorry, tendon and ligament destruction. Sometimes there will be a destruction in a tendon and what? The ligament, or even bone fractures. Bone fractures. So as I said, it varies from age to age. So maybe adult like above 45, you see majorly from accident, maybe motor vehicle accident, or maybe are, they are in the bedroom, a place that is slippery and they fall. Yeah, children own is normal. They keep falling up and down because they run from place to place. Yes, and maybe during sports, depending on the age anyway. Then for the elderly, this one falls. A slight fall can even cause fraction in the elderly because you remember in the last physical class we had, I told you about a curve that goes like this. This part, the origin is like denote the neonates, newborns, as they are growing, the peak of the max, the maximum level, the peak of the curve is more like the peak of adulthood, maybe 40, 50 years. Then after that now start coming down to the other end where the curve touches the x-axis. At that point that denotes the elderly. So most of the things you see in elderly, some of them you see in the what? In children. But the children own is that they are still forming, but the elderly own is that their own, most of the things are going down. The cells are going down. They are not that strong again. The bones are no longer the way they used to be. So any slight fall can lead to what? Fraction, especially around the hip and the proximal part of the what? Proximal part of the humerus. So now that is for the bones. So let's look at soft tissue injuries that you may see. You may see things like contusions, that is tissue damage without breaking the skin. You can see hematomas. You see in a particular part of the body, you see a localized collection of blood. That's what you call hematoma. Or even laceration, skin cuts. So these are examples of soft tissue injury. That is the muscles. The first one is bones. Remember, we are talking about musculoskeletal system and joint disease. I talk about the bones. The second one I talk about is the muscles. Now, the last one I want to talk about is what? Injuries, common injury and trauma that are associated with joints. Now, of course, overstretching and twisting can lead to joint problem. It's very important you know that. Overstretching and twisting. So basically, you see things like sprains. See if I'm wrapping some sprain on the board. So that's can you see the board clearly? Can you see the board clearly?
Yes.
Good. So I forgot that I have board here. So there are some things I will mention. You see how the despairing and all that. Even though you see get like cost material. But I talked about sprain. Sprain, okay? Good. Now, so we have sprain is there. What is sprain? Sprain is a ligament injury. Remember ligament, that one is for ligament injury. sprains. For what? Ligament. Then we have strains. Strain is for muscle or tendon injury. More of tendon anyway. More of what? Tendon. Why I added muscle? You know that muscle is like this. Muscle is like this. Depending, but at the end of the muscle, we have your what? Tendon. We have your what? Tendon. And it is the tendon that attaches the muscle to the bones. So that's why I just leave it at muscle / tendon injury. Then we also have lacerations. We also have lacerations. 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 Sorry. What am I saying? Don't mind me. I've discussed this before. I'm talking about rupture. Rupture, sorry, not laceration, rupture, even though they look alike. Rupture here you see, it's not just about strain or spray, that's complete tear. Complete what? Tear. It's not about sprain, it's not strain, this one is complete tear, and it's a problem too, and it's painful. So let us not dwell so much on this. Let's go to the next. This is the first issue, musculoskeletal, the disorder you see. The next one is rheumatoid arthritis. Rheumatoid. Please, anytime you stop seeing the board clearly, let me know, okay? Please don't keep quiet. Next one is rheumatoid arthritis. Rheumatoid arthritis.
Sir,
Yeah,
I have a question.
ask.
When you are mentioning the classifications of joints,
Okay.
you mentioned the three, but I did not hear them. Maybe you can kind of, yes, I didn't hear. Maybe since you are using board now, you can please help write with the board. I
But
didn't
say
get them.
you will still get this lecture. Why
Okay,
going back and coming forth? You will still
okay,
get the recorded lecture, please.
okay, no
So don't
problem.
waste time.
Go ahead. Go ahead.
If it is something that you need explanation, but this one is going back to what you have said, it will
Okay.
please understand. Thank you. Now I'm talking
Um,
about rheumatoid what? This matter
arthritis.
is not matter. The marker is not marker. Okay, let me get that. Rheumatoid what? This one is even the most. Can you see it? It's faint.
No.
Can you see? Can you? Can you see the board? Can you see what I just wrote now? Is it clear?
It's faint.
No,
The arthritis is faint.
it's faint. All right. Can you see it now?
Yes, it's
Okay.
better.
Rheumatoid what? Arthritis.
Arthritis.
What is rheumatoid arthritis? In fact, rheumatoid arthritis is just like a body. It comes as a result of the body fighting itself. The body fighting what? Itself. That what lead to this rheumatoid what? Arthritis. Here you see the is an autoimmune disease, immune system fighting, attacking the part of the body. And at the end, it will lead towards rheumatoid or arthritis. So it's a chronic systemic inflammatory disease. It affects the synovial joints. It affects Osteoarthritis and rheumatoid arthritis are not the same thing. Rheumatoid arthritis affect the synovial. Rheumatoid arthritis is autoimmune, but osteo is not. So rheumatoid arthritis affect the synovial joints, resulting in cartilage and bone destruction. So it occurs across the genders, male or female, but it is more in women. You can testify to that. It is more in what? Women. And the peak onset is around 30 to 50 years. Please, let me tell you, please, so I beg in the name of God. Let me go, let me tell you, please, so a lot of girls, a lot of our students in class, every morning they come to school, the first thing they go and buy is they go and buy carbonated drink. They will not eat food. They will buy carbonated drink. Come to class, they buy egg roll or bread. Then after school, they'll go home and cook noodles and eat. And they will not eat any other thing again. Tomorrow again, they will continue. You are preparing a table for arthritis to deal with you as you are getting to 40 to 60 years. Even from 10%. So be careful about what you eat, because most of these chronic diseases come as a result of what we eat. Be careful about what you eat. You will see fruits, you do as right. Even if you don't want to eat something heavy, you can take fruits. Whatever is there, whatever you want to take is there. Take it. It's okay than all these junks you are eating. Please, let's go back to that. The point, the lecture. It's very important you understand this. Okay. So this peaks at 30 to 50 years. The highest incidence is around 40 to 60 years. As I said before now, it is mainly autoimmune disease, immune system mechanisms. Even though, yes, it may still have some genetic undertone. Now, it causes prolonged joint pain and stiffness. It affects the fingers, it affects the hands, it affects the wrist joints there, the knees, the feet, even the cervical spine. So it's very important we understand this. And I wouldn't want to go into this. Another one I want to look at is gout. Gout. Gout is also another musculoskeletal system issue. Gout. What is gout? Gout is a disorder caused by what? Uric acid, some product of metabolism. Another things will now go and get deposited. Get what? Deposited as crystals, specifically uric acid. Uric acid will now go and get deposited as what? Crystals. And it looks as if everywhere is blocked around the joints. So it's a problem. So how does, in fact, what will you see? You see that how does apart from the joint, there are other places it can manifest. Let me just run through it. This gout is manifested as acute gouty arthritis. Acute gouty arthritis. It's also manifested as too fly in the joints and soft tissues. Remember, it's crystal. Tissue that is supposed to be soft. You start feeling something is deposited in it. It can also be manifested as kidney stones. If you have after this class, go and look for a picture of kidney stones. If you see somebody, just you see a sliced kidney, you see things like stone. It's actually that thing is uric acid in crystal form, and it leads to serious neuropathy. It's a problem, but the stone need to be removed, and this can lead to kidney failure. Now, rapid rise, rapid rise in the level of uric acid can trigger attack. The common site you see is in big toe, in the big toe. You know what big toe is now? The big toe is the first meta. You okay? Sorry, you say sorry. Not stress. You said you've not done skeletal system, but it's important you know this. The big toe, the official name for the big toe is just for general knowledge. But you remember, we are health professionals. We don't just we are discussing. I'm discussing with you as health professionals. You know, as those that are into healthcare and you know about anatomy, physiology. The actual name is what? First metapharyngeal joints. Basically, that is the joint in specific joint we are talking about now. The first meta. You know we have metatarsals. Remember, it came from metatarsals. First metatarsus. Sorry, metatarsus. Then phalanges, pharyngeal joints. Sorry, let me admit some people. Our latecomers in the house. Victoria, why are you coming now? Victoria, eh? Why are you coming to class now? What is all this? Hmm? All right, let's continue. Okay, so let's say just a little thing about osteoarthritis. I have told you the difference between osteoarthritis and what? Rheumatoid arthritis. Osteoarthritis is the common arthritis in the elderly adults. Is found more in the elderly because it is associated with chronic degeneration of cartilage as the person gets old. That one, the chronic degeneration of what? Cartilage. The management of this one is just mainly on what? Pain relief and improving functions. That's all. So I wouldn't want to go into that, deep into that. Now, let us now go into what I just did now. If you understand what I just did now, I just ran through the what is it called? The physiology, just an overview, not too deep, of the musculoskeletal system. And I went towards sorry, I mean anatomy of what I just did now, anatomy of the musculoskeletal system in overview, physiology of the musculoskeletal system, and the pathology, that is disease conditions associated with the musculoskeletal system. So that's what we just did now. Now let us go into drugs. So we don't waste time. Medicines we need. So the first set of drugs I want to talk about is the skeletal muscle relaxants. Skeletal muscle relaxants. Skeletal muscle relaxants. Skeletal muscle relaxants. Excuse me, I'm coming. Give me a few seconds, seconds, I'm coming, please. Sorry. Yeah. Let's use number now. Okay. Okay, let's go. Skeletal muscle relaxants. So that's the first set of drugs we're going to look at. So from the name, skeletal muscles, relaxants. You know that they act mainly on the muscles, skeletal muscles. Relaxant. So for them, you know what they do. You know, if there's spasm, uncontrolled contractions of the muscles, skeletal muscles, these drugs there are there to do their job. So let us not waste time. So muscle spasms that can come from injury, muscle spasms here. Muscle spasms that can come from injuries. They respond, that rest. They respond to rest. Sorry, I mean rest as in just rests. They respond to rest and simple analgesics. We know. Just simple spasm, muscle spasm by just resting and using simple analgesic, they can be taken care of. But spasticity, very important. Spasticity, that is this spasm issue that come from neurological conditions is not what resting can take care of. And it's not what simple analgesic can take care of. Spasticity from neurological conditions requires long-term medication. So, what do these skeletal muscle relaxants do? They act by depressing the central nervous system motor pathways. Central nervous system motor pathways. Or it can alter calcium availability. You know that calcium plays a vital role. Calcium plays a vital role in contraction. I remember that origin of spasm is contraction. When a contraction is out of it, and calcium plays a vital role in contraction. I wanted to understand what pharmacology is. See how I'm breaking it down so you understand the basis for complex things you see or hear in pharmacology. Simple, okay? And so I wouldn't go deeper than this. Let me see. See somebody is waiting to be. You see somebody is waiting to be admitted. Not even somebody, 3 people. Oh, wow. Oh, wow. Okay, let's continue. What do I do? Okay. So let's look at the first under this skeletal muscle relaxant. The first group I want us to talk about, the first subclass I want to talk about neuromuscular blocking agents. 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 So from the name, from the name, you know what happens. They block transmission of impulse at the neuromuscular junction. If you do your nervous system in anatomy and physiology, you appreciate this. But you appreciate what I just said now. So there is this, of course, now, of course, you remember I told you that these muscles are innervated. These muscles have nerve supplies. Because without the nerve supply, they are vegetable lying there. They cannot move, nothing. So because of the nerve supply, so transmission of impulse from the nerve, neuro, to the muscle, muscular. So the junction where the nerves and the muscle meet, that is what we want to call the neuromuscular junction. So there's transmission of impulse at this point. Is that impulse that helps in the contraction? So because you want to stop uncontrolled contraction, that is the spasticity, neuromuscular junction, at that point where the nerves, the neurons supply, transmit impulse to that muscle that causes that contraction. At that point, that you have some drug that can block that transmission of impulse, at least to control the spasm, because the spasm is no longer normal. It has gone beyond it is uncontrollable. So that's what we mean by the neuromuscular blocking agent. I wouldn't go deep into that. So this is the basic understanding at your level. You should understand so that when you now come up, you appreciate it better. So the classes, we have the short-acting ones. Short-acting neuromuscular blocking agent. Short-acting. So I'm writing their names so that you appreciate it. Short-acting. I'm going to give one example here. Short-acting neuromuscular blocking agent. Example is what? Succinyl. Can you see the board? Is it clear? Is it clear?
Yes.
Good,
Yes.
Succinyl choline. Succinyl choline. Are we together? Succinyl. Also call it succinyl. Succinyl choline. Acetylcholine brother. Because they sound alike, don't mind me. So this one is what? Succinyl choline. It's short acting. This one is what? Short acting. So we have intermediate acting. Intermediate. That is in between. Intermediate acting one. You see drugs like atracurium, cisatracurium, urocuronium.
So how much like
I know you shall write it on the phone. Can you see it?
sir? Yes,
Can
sir.
you see it? Atracurium.
I can't see it too.
Are you serious? Okay, let me write it.
Yes, sir, you can't see it.
Can you see it now? Huh?
Yes, sir, I can see it.
Good.
It's not clear.
If at this point it's not clear, then that means it's from your end. Please mute your mic, please. Mute your mic, please. Atracurium. Cisatracurium. Cis. Atracurium. It's actually cis. Atracurium. cis. I don't want to go into mirror images and the remember. Can you remember what I taught you about what we discussed about stereochemistry, isomerism, and all those things? Can you remember? Can you remember? In our last class on drugs, we discussed, I told you about cis, trans, levo, dextro.
Yes,
Can you
sir.
remember? So please,
Yes,
this is
sir.
how this one is cis atracurium. Cis atracurium. So this is cis atracurium. Cis atracurium. Then we have rocuronium. Rocuronium. So these are some of the examples of intermediate acting neuromuscular blocking agents. Are you aware that you have actually started AUM now officially? From now on, you're hearing names of drugs. So take every lecture now from henceforth very seriously. So you can have the foundation. Even if you miss the lecture, make sure you watch the one recorded one. It will help you to have strong foundation. Is that
Yes,
clear?
sir.
Good. Now, so these are
Yes,
some of the
sir.
examples of what intermediate what neuromuscular blocking agents. So let me go back to the long acting. This one act for a long time. Long acting neuromuscular blocking agent. We have things like doxycycline. 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 We also have mivacurium. Mivacurium.
Sir, I can't see the board. Sir. Excuse me, sir.
You can see the board. Sorry,
Baby,
I don't know what else to do. I don't know what else to do. Sorry. I have increased the fonts. I don't know what else to do. Doxycycline, mivacurium. Then we have pancuronium. 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 These are some of the examples of what? Long-acting neuromuscular blocking agents. Okay? Good. Let's continue. So I have already told you how this one works, but let's just go deep a bit. Let's look at their mechanism of actions. Mechanism of what? Actions. Remember, I told you that they block transmissions at the neuromuscular junction. In fact, in autonomic, in parasympathetic nervous system, the major neurotransmitter that leaves the nerve to the muscle and initiate all those contractions is acetylcholine. Acetylcholine. Acetylcholine is the neurotransmitter. Acetylcholine. So what these drugs I mentioned do is that these drugs, one, they work by what? By blocking competitively because look, they made them to look alike as if they are acetylcholine. Where acetylcholine is supposed to go and bind, this one will go there and block it. We call them, we call it competitive. Remember in our last class, we did competitive antagonism. True or false? We talk about antagonism, right? Where a particular antagonist will go and block the receptor. Can I remember in our last class? No, last two classes. Please go back to your course material. So this one, they do what? They block the what? Acetylcholine what? Receptors. Then we have those among them that are depolarizing in any way. I didn't go deep into that. Depolarizing. This one persists longer. They mimic acetylcholine and persist what? Longer. Example is succinylcholine. This one now, this one mimic acetylcholine. That's why when I mentioned it before, I laughed. I said acetylcholine product. It mimics acetylcholine, and because of this, it lasts longer. It persists, even though it's short acting. So, what point am I trying to make here? In summary, these drugs block what? They block what? Neurotransmission. This one now is acetylcholine specifically. They block here. So, what do we use this? What do we use this muscular blockers to do? What is the indication? They are used in surgical muscle relaxation. Remember, they cause relaxation. So surgical muscle relaxation, they are used in surgical muscle relaxation. And they are also used to control, they're usually controlled respiration and even in orthopedic manipulation, basically. Orthopedic what? Manipulation. What side effects can this drug give? They can cause drowsiness, seizure, they can cause hypotension, they can cause muscle weakness, and even arrhythmias. So these are the side effects of this drug, adverse effects. They are contraindicated in those that have history of hypersensitivity to it, or maybe something like people that have long history of malignant hyperthermia. It's also contraindicated in pregnancy. They are contraindicated in children less than 2 years. They are also contraindicated in those that have myasthenia gravis, specifically for atracurium. Atracurium. Are we together? Now, don't worry, after you listen to this class and you watch your get your course material, so we don't keep wasting time. You don't feel bad, okay? If you are not seeing some things on the board or whatever, just you see here what I mentioned, please. So don't waste time. Okay. Then, apart from this first group I mentioned, there's another group we call centrally acting skeletal muscle relaxant. Centrally acting skeletal muscle relaxant. Centrally acting skeletal muscle relaxant. Examples of centrally acting skeletal muscle relaxant include baclofen. So let me write it boldly. Include baclofen, include carisoprodol, carisoprodol, even cloxazone, 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 cloxazone. 4 syllables. Cloxazone. Another example of this one is cyclobenzaprine. Cyclobenzaprine. Another example is diazepam. You are used to the diazepam now, right? This one may not. Baclofen is common anyway. These two may not be common. Even this clozazole is also common. But the commonest among them is diazepam. So no need right among them. We see in the pharmacy around is what? Diazepam, metocarbamol. That is your Robinax. Metocarbamol, your Robinax, for those that know about it. Who have seen Robinax before? Metocarbamol, 500 milligram. Who? Talk to me now. I ask a question. Are you with me?
Yes, sir.
I said, who have seen
Yes, sir.
metocarbamol before?
I don't know it.
Who have seen it? Where are those people that did?
Sorry, I'm not sure.
You said what? You said what?
We are just hearing the name. Don't strange to us. We
Are
can't
you
hear.
serious?
Except from that, the farm.
Except from what? Except from what?
Mention.
That is bad.
And
Don't worry. Don't worry.
amlopentine, haloperidol.
No, you today. No what? Don't worry. Let's continue. Don't worry. I understand. So, but metocarbamol is what is Robinax is a popular medicine in the markets. Hope you know that metocarbamol is drug. Why Robinax? The product from that drug is what? Medicine. Because Robinax is a preparation from metocarbamol. So let me not go deep into that. So let's continue. So meto what? Carbamol. Then another one. If you don't know this one, I will chase you away from this class. The last one I want to call now. If you say you have not you don't know about them, they are problem somewhere. Ofenadrine.
Fatigue and co.
Ofenadrine.
I have heard of it.
Yes,
I know Fenad. I've even taken it.
I'm happy. At least one person has seen it, and one person has. Now you come. Now you come. Thank you for that. At least I'm happy. Good. Let's continue. So it is proposed that this particular class of drug, they depress the polysynaptic reflexes. It is proposed that they depress the polysynaptic reflexes in the CNS. different schools say that their mechanism of action is not known, but it is proposed that they depress the polysynaptic reflexes in the central nervous system. Polysynaptic reflexes. Polysynaptic. So of course, you know, because due to the fact that this acting centrally, it is CNS, there's tendency for it to cause sedation. That one day. There's tendency for it to cause sedation. Person start feeling like this
Yes.
because it's acting,
Yes.
they're acting on the central nervous system. So this sedation contributes to muscle relaxation. That is what was proposed. So it is used, what are their uses? Sorry. They are used in what? Spasticity. I think I read it before. Spasticity conditions such as cerebral palsy, multiple sclerosis, spinal cord injury. Cerebral, after all these things, you go and check what they mean by that. The word has changed. Just use your phone, check what they mean, please. Cerebral palsy, multiple sclerosis. Let me engage you. Someone is there, sir. Someone there can check what they mean and tell us now as lecture is going on. Someone there in the class can check what this is and tell us. I want you to get involved in this. Then spinal cord injury. What are their adverse effects or side effects? Weakness, drowsiness is common. Drowsiness, dizziness, and what have you. So what condition can you not use it? That is contraindication. It cannot be used in some heart conditions. In some heart condition, choose like this cyclopentaphrine, benzapine. Then even in pregnancy, they should not be used in what? Pregnancy. They should not be used in what? Pregnancy. And they should also not be used in children under 5 years of age. Let's look at direct acting skeletal muscle relaxants. Direct acting skeletal muscle relaxants. We have discussed neuromuscular blockers. We have discussed centrally acting and the examples. Then look at direct acting skeletal muscle relaxants. Direct acting skeletal muscle relaxants. Examples. Hey, I have not been admitting people. Oh. Sorry. Idowu the late comer. Idowu the late comer. Let's continue, please.
Sir, we can't hear anything. Oh, we can't hear you.
You cannot hear me at all? Huh? You cannot hear me at all?
We could hear you before, but now we can't hear you again.
You
Oh.
cannot hear me, but you can hear
We only see your mouth movement.
but you cannot How can you not hear me now? But and you're discussing with me. How? For you to discuss with me, that means you can.
Sir, maybe we should end the call from our end and rejoin again. We can't hear anything. I'm not hearing anything, sir.
But you can hear me now. Sorry. But you can hear me now.
Yes, we can hear you now, sir.
Okay, let's continue. Since you can hear me now, let's continue. I said we have the next class group we will look at is directly acting or direct acting skeletal muscle relaxants. Direct acting skeletal muscle relaxants. Direct acting skeletal muscle relaxant is another class of skeletal muscle relaxants. Common example I want us to look at is just dantrolene. Dantrolene. Quinine. At least you know quinine now, right? That you are quinine.
Yes, sir.
Dantrolene, quinine. There are other examples. Even botulinum toxin A and B. Botulinum toxin A and B. These are examples of what? Some of the examples of direct active one. So, what does this direct acting skeletal muscle relaxant, what do they do? This class decrease calcium release from the muscle cell. And when this happens, they make the muscle less responsive. So in summary, I said that they decrease calcium release from the storage sites. So making the muscles to be less responsive. Remember, it is hyper responsiveness, contraction that can cause what? Spasm, can cause what? Spasticity condition. So this one now directly prevent calcium from doing its work. Are we together? So they are used in the treatment of the spasticity from the upper motor neuron lesions, injury, upper motor neuron lesions. And they can also they're also used in malignant hypertension. Upper motor neuron lesions. Upper motor, neuron lesions. Lesions. And in malignant hyperthermia. Malignant hyper. This is right. When you get your customer there, you see them. Hyperthermia, MIA. So what are the side effects? Adverse effect of this class? They cause muscle weakness. Virtually most of these drugs cause muscle weakness. Virtually all of them. They can cause muscle weakness. Dizziness is also there. They upset the gastrointestinal tract, and they can cause seizure. and tachycardia. It can cause muscle weakness, dizziness, gastrointestinal upsets, tachycardia, and seizures. Now let's look at, we are done with skeletal muscle relaxant. That is the level I can go for this class, for this level. Okay. So let's go to the another class of drug. These ones are called anti-rheumatoid drugs. Anti-rheumatoid drugs. Anti-rheumatoid drugs. Slow-acting anti-rheumatoid drugs. Or simply say anti-rheumatic drug, better said. So I will list some of the examples, then we'll take it on from there. Remember what I told you about rheumatoid arthritis? Remember, don't forget to. These ones are also known as DMARDs. I didn't want to take you there, but just understand that DMARDs. Remember, I told you that in my class, always make sure you have access to information, because I can't be telling you everything. There are some things I will mention. I'll ask you to find it out and let me know. I can't be telling you everything, because if I continue, we'll not be able to do anything. And it's something that are direct. You are supposed to just use your phone, find out what it is. Something that needs explanation, then I cannot go down and explain. So this has been my method, please, and I stand on that. It's very important, because the more you search these things yourself, the more you retain them. But if you sit down, I'll be giving it to you, you may not appreciate them. Very important to understand that. Okay, so now let's look at the examples of these drugs. The first one I want to write on the board is methyl. Methotrexate. Methotrexate. If you watch, I'm teaching you how to pronounce these drugs, because it can be embarrassing. If you go to somewhere to do presentation and you cannot pronounce what you are presenting. So I'm even breaking them into, in fact, I'm even teaching English language ESL, oral English. So to make you understand it's very important you understand that this, how to, you know how to pronounce the things. It's very important. Methotrexate. These things are not difficult. Just once you can break them into the different syllables, you are good to go. Methotrexate. 3 syllables. Methotrexate. Then we have gold compounds. Gold compounds. There are some drugs under these gold compounds. You see something like auranofin from Ara. You see something like gold sodium thiomelates. Gold sodium thiomelates. Gold sodium thio. Thio is from sulfur. Anytime if you hear thio, just know that it's talking about what. Let not take you there, please. Leave it at that. Thio. THIO. Thiomelate. Gold sodium thiomelates. Aura from Ara, auranofin. Methotrexate. These are some of the examples. But these two are under gold compounds. Please, gold compounds. So I've mentioned methotrexate and gold compounds. Then we also have other examples. Penicillamine or penicillamine, whatever how you want to call it. From penicillin, you can get the pronunciation. Penicillin from penicillin, okay? You can get the spelling and look at it. Penicillin. Sorry. That should be I-N-E. What am I even doing? Penicillamine. Wait, let me see somebody. Okay. So penicillamine or penicillamine. Good. Another example is sulfasalazine. 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 Then another example is hydroxychloroquine. Hydroxychloroquine. It shocks you that the anti-malaria and the modified anti-malaria are appearing here. It shocks you. Hydroxychloroquine. Hydroxychloroquine. So we have methotrexate, gold compound, under gold compound, auranofin, and gold. I thought about thyro what? Remember? Thiomelates. I said gold sodium thio. Gold. Let me not waste my time on these things. I have to talk about it before. We have methotrexate, gold compound. Under gold compound, auranofin and gold sodium thiomelate. Then we have, after that now you start with this one. And then penicillamine, hydroxychloroquine, sulfasalazine. Since I'm wasting too much time trying to explain this thing, but it's important. I do so you understand what I'm saying.
Yes, sir.
So what is what is the adverse effect? They have issues, they cause gastrointestinal issues. They can cause mucosal lesions. They can cause dermatitis and even bone marrow suppression. They can cause bone marrow suppression. That's an adverse effect you can see. Now, when should we not use them? In renal disease. Patients with renal disease should not use them. And also patients that have history of good toxicity. Then pregnancy, a pregnant woman, irrespective of the trimester, should not use these drugs. Let's go to another group of drug for gouty arthritis. Drugs for gouty arthritis, the one you call gout. Gouty arthritis. Drugs for gouty arthritis. The first one I want to talk about is what? Colchicine. This one, wonderful, is a good anti-gout drug. It has anti-mitotic effects, but it's very toxic. That's the issue it has. It's very what? Toxic, and it can cause GI disturbances. It's contraindicated in ulcer patients. Contraindicated in ulcer patients. The one that is popular, very, very popular, you see that one almost all the time. So some mentioned it before. Allopurinol. No be so. No be so. Allopurinol. This one, what this one does is that it inhibits xanthine oxidase. It inhibits xanthine oxidase, play a vital role in uric acid metabolism, things concerning uric acid in the system. It plays vital role. So this now, they inhibit xanthine oxidase, or xanthine, as the case may be. It's an enzyme of please, xanthine oxidase. So if this enzyme is inhibited, synthesis of uric acid will be prevented, because it is the accumulation of uric acid to form crystal that leads to gouty arthritis. Since it's because of this now, excess of it can cause this. Also, you are pleased, not just if I say uric acid, we think it's just there. Please, this one also has to do with what you eat. Eat well. Eat well. What you eat matters too. Yes. Please note that, okay? So, if this enzyme is inhibited, then the uric acid synthesis will be what? Truncated. Uric acid synthesis will be what? Truncated. Therefore, thereby preventing uric acid formation. So there will be no much uric acid to even think of, the one that will go and get accumulated. Because when they get accumulated and become too much, they form crystal, they solidify and form crystal. They form crystals, crystal deposits. So this drug is used for gout and uric acid kidney disorder, kidney stone. Please know that point. It's used for what? Gout, and uric acid kidney disorders. That's your kidneys, the kidney stone we were talking about. Its adverse effects include rash, hepatotoxicity. So the liver can be toxic to liver, depending. Even bone marrow suppression. But the benefit, when the benefits surpasses the what? The risk. You have to use it so you can take care of the patient. The bone marrow suppression. This drug can interact with things like warfarin, azathioprine, amoxicillin, and other drugs. Amoxicillin, azathioprine, and other drugs I mentioned, warfarin, why you call warfarin, and even other drugs. Let me stop here, please. And other drugs. So This lecture will end here. I don't want to us to stress it too long. So please remember, I told you I sent the link where you can join Telegram channel, where you have access to where you have access to where you have access to pharmacology textbooks you can download and study. Okay. Yeah. On that, I will send you this material that is other material that you help you to get grounded in this topic. But this is the basic thing you need to know at this level. If you watch, I'm trying to not to go too deep because to avoid throwing you off balance. But this is basic thing. If you have this foundation, any textbook you open to read, you are good to go. All right, so let us not waste time on this. Any question? We have barely how many? Just a few minutes for us to look at our practical. Any question? Any question? Please, if you have a question, please ask. All these drugs I listed today, please ensure you know them, know where they belong, know what they do. That's the basic thing you know. This is action and uses of medicine. All those one I mentioned, know where they belong, know their names, know what they do, know their class. That's the basic thing you must know about all these drugs I mentioned. Any question, please, someone should speak to me. No question. If you keep quiet, it means there's no question. No, that's the meaning. But let me be sure you can hear me. Can you hear me?
Yes, sir.
Okay, so since you can hear me, that means there's no question. All right, we'll stop this lecture here. Don't go because we are going to the BDP 231. We just have a few minutes. I want to do one or two calculation on the board. I told you about it last time. All right, thank you very much. God bless you. Don't go. I'm coming back for BDP.